Herzlich willkommen bei Klinisch Relevant, deinem Wissenspartner für das Gesundheitswesen. 3-mal pro Woche, nämlich dienstags, donnerstags und samstags, versorgen wir dich mit unserem Podcast und bringen dir Fachwissen in deine klinische Praxis. Weitere Informationen und Angebote findest du auf unserer Webseite www.klinisch-relevant.de. Heute hörst du eine Podcast-Folge in englischer Sprache, die wie immer von Laura Reynolds gehostet wird. Sie spricht hier mit Professor Reza Wakili über das Thema Vorhofflimmern. Viel Spaß beim Zuhören.
Hello, my name is Laura Reynolds, bringing you an episode of Klinisch Relevant in English. I'm joined today by Professor Reza Wakili, Assistant Director of Cardiology, Vascular Medicine and Head of Rhythmology at the University Hospital Frankfurt. And we're going to discuss the new guideline for atrial fibrillation from the European Society of Cardiology, which was published just last year in 2024. So I'm excited to get the updates, which is going to help me in my clinical practice. And thank you so much for joining us and sharing your knowledge.
Yeah, my name is Reza Wakili. I'm working at the University Hospital in Frankfurt. My focus is, beside my cardiology occupation, is electrophysiology. So I treat on a daily basis patients with heart rhythm disturbances. In this aspect, the whole spectrum from inherited cardiac diseases, patients which undergo ablation, patients which receive or undergo device implantations, defibrillators, or just get any kind of antiarrhythmic drugs or oral anticoagulation for stroke prevention. So I'm very happy to be here with you, and thank you very much for the invitation.
Well, you're definitely then the right person to be talking us through the new guideline. So yeah, we said we were going to keep a focus on what's new and what are the updates. And yeah, let's dive right in. I think there's the new therapeutic approach to atrial fibrillation, the AF care model. Would you be able to talk us a bit through that?
Yes, of course. Like the main focus which is new is the C for care. And it really is related to treating the comorbidities or the underlying causal factors which are actually contributing to the AF onset, AF development, and the maintenance of AF, atrial fibrillation. So what the authors did is like put that more in the front. It was already in the previous guidelines, but there in the end. It was there in A, B, C, so it was the end, and now the C came up front. And to really think about what are relevant comorbidities in the patient which have to be treated and which have to be addressed by specific treatment by the physician. I give you some examples. Hypertension is a very, very important risk factor which we deal with on a daily basis, but some of the physicians and the patients are not aware that this has to be controlled, re-evaluated, and really optimally treated with drugs, and has to be also further controlled during follow-up if the drugs are still sufficient to really regulate the blood pressure. Another thing is obesity. So we know that obesity as such is a risk factor for different other stuff like diabetes, like hypertension, sleep apnea. So we know that patients which are obese, if they lose weight in a controlled manner, that this will help and improve the success rates or outcome of any rhythm control strategy, either carried out by drugs or by ablation therapy. So also controlling weight and giving the patient a guideline and really some like treatment recommendations with respect to his weight is very important. And the other thing is, for example, that in this context, GLP-1 analoga, like it's very famous. All the people talk about Ozempic as the weight loss, the weight loss injection. So if people are really obese and have pre-diabetes, this is for sure a very good treatment for these people to help them to lose weight, to get the metabolic remodeling more on the beneficial side back again. So these are really potential therapeutic interventions which are really useful in these patients. And our other one is treating heart failure, which heart failure in different categories, if it's heart failure with reduced ejection fraction or mild reduced ejection fraction, or also with preserved ejection fraction, are known risk factors which contribute to the onset of atrial fibrillation, but also in the combination, meaning that two entities come together like heart failure and atrial fibrillation, is really worsening the prognosis of these patients. So in these patients, the impact of F is much more important than in patients without heart failure. So we think heart failure treatment is important to get the AF better, but also treating the F in the heart failure patient is important to improve the outcome of the patient. So we have to treat these patients, and the SGLT2 inhibitors like empagliflozin or dapagliflozin gained a lot of attention during the last years, are also part now of the new guideline for heart failure therapy. And I think all patients which have a diagnosis of HFrEF, have MREF, or have PEF should really be described with an SGLT2 inhibitor as one of the basic medication treatment, let's say, columns, which is really important for this patient. So we call it now a metabolic remodeling, which we want to reverse to get the diabetes patient less diabetic, to get the obese patient less obese, to get the hypertension patient in normotensive blood pressure ranges. And it continues with other comorbidities like coronary artery disease has to be revascularized. Valve diseases have to be reconstructed minimally invasively or by surgery. So these are things which have to be optimized and have to be but assessed at baseline to see, okay, which are risk factors which are relevant in these patients and how can that's the C, which is really one important thing. And the A is about oral anticoagulation as preventing stroke, which is the most important risk in patients with atrial fibrillation. Still, the people die from a really severe stroke. That's the only direct, vitally, let's say, dangerous risk if you suffer from atrial fibrillation is the stroke. So the most important thing is to prevent stroke in these patients which are at risk. So you have to assess the stroke risk in the individual patient, and then if the patient has a certain stroke risk, you have to prescribe oral anticoagulation drug to prevent this. And what is also new here is that the risk certification got more straight and easier because risk certification is carried out based on the so-called CHATS-VA score now. It was CHATS-VASC score, so sex mattered in the old in the old guideline, but since this risk factor was pretty weak, they got rid of it so that the gender or sex doesn't play any role anymore in this risk certification. We have congestive heart failure, we have hypertension, age as such, diabetes, a previous stroke, and any kind of vascular disease, which are relevant factors to be evaluated. And if you have a CHATS-VASc score of 2, you have to be anticoagulated. If you have a CHATS-VASc score of 1, it should be considered as a potential therapeutic consequence to prevent stroke. If you have a CHATS-VASc score of 0, then your stroke risk is so low that you would harm the patient more with a high bleeding risk if you put him on the anticoagulative drug than to prevent him from stroke, since the risk is not really beneficial. This is also something which was new. And if we come to R, like rhythm benefits to improve the rhythm, then we must say as an interventional cardiologist that the role of catheter ablation, which is one potential option in patients to control the rhythm, gained a lot of, let's say, more evidence based on randomized trials during the last decade, I would say, or decades, I must say. So it's very obvious and proven really consistently that a catheter ablation, which is performed out with a catheter in the left atrium, electrically isolating the pulmonary veins, is the most sufficient and most effective way to keep a patient in sinus rhythm when he's suffering from atrial fibrillation. And the second line, with respect to effectiveness, is antiarrhythmic drugs. And in the previous guideline, we said, okay, the patient should be initially more be prone to get an antiarrhythmic drug, but it's a matter of discussion. And then as a second line therapy, catheter ablation comes in the game. But now based on the cumulative evidence, now we have the option that catheter ablation is a class 1 indication with the highest recommendation as a first-line strategy therapy option in patients suffering from paroxysmal atrial fibrillation to keep them in a stable sinus rhythm. So this is for sure another novelty, which is, from my perspective as an interventional electrophysiologist, a very important thing is then to be believed in this therapy. We provided evidence in the past, but since it's invasive, the old guidelines were a little bit more conservative, but now we have a class 1 recommendation for these patients to really keep them in sinus rhythm. And still, as an alternative, we have the antiarrhythmic drugs, which can be described, and based on the certain comorbidities, we have a certain option of these drugs. Came from healthy individuals with atrial fibrillation class 1C or class 3 antiarrhythmica like flecainide, propafenone, or amiodarone. Then we have patients with coronary artery disease in which sotalol or dronedarone as a backup is still an option, and amiodarone. And if you have patients with really reduced ejection fraction, then amiodarone is the only option which is left. And you can also combine them both, but it's a clear statement towards catheter ablation as an established therapy of rhythm control in the new guidelines, which is also very new. And the E is standing for really, let's say, that you still control all these risk factors on a longer period, that you follow up the patients and reevaluate the patients with respect to, is the hypertension still intact? Does he still have sinus rhythm, or is there the recurrence of the atrial fibrillation? Has to undergo a second ablation, or has to receive an additive other treatment? So the reevaluation of the patient after initial assessment and treatment strategy is the fourth point in this AF care scenario and this scheme, which means, okay, after you treated it initially, you have to follow up the patient and reevaluate in certain terms if all the risk factors, if the atrial fibrillation has changed, if new measures are required with respect to therapy optimization in individual patient. And what we have also strengthened is that if a patient cannot be kept in sinus rhythm, so we accept the atrial fibrillation and we pursue a strategy of so-called rate control to keep the atrial fibrillation in a certain range of heart rate, then the option of putting in a pacemaker, so a pacemaker implantation and getting rid of the AV node by an ablation, got also stronger recommendations in the current guidelines, since we have a lot of evidence that this is the most efficient kind of rate control, getting his bundle of AV node ablation and having a pacemaker, which is really perfectly regulating your heart rate range. And the patients seem to benefit in this respect from this kind of treatment. Also, this got more strengthened as a recommendation for the patient. And the last novelty, which I think is important, is that the surgical approach, like from heart surgeons, not the minimal invasive approach, got also more stronger evidence based on randomized trials. So in patients which initial endocardial ablation by catheter ablation was not successful, epicardial ablation can be performed. And especially if you are undergoing open heart surgery and you suffer from atrial fibrillation, there is now a clear recommendation that these patients should undergo concomitant ablation during the open heart surgery. Since you're already there, you have already the atrium in front of you, so the surgeon should also perform a surgical ablation while he's operating on the heart. This is for sure class 1 indication for mitral valve surgery, but also class 2 indication for patients which undergo CABG, for example. And the other thing which got more supported by the guidelines is that was something speculative in the past, is if the patient suffers from atrial fibrillation and he undergoes open heart surgery, the surgeon should close the left atrial appendage. Since there was a new trial, the last 3 trial, which showed if patients get surgical occlusion of the left atrial appendage and have on top additively oral anticoagulation, they have a lower stroke risk. So it's not either one or the other. So it's having both oral anticoagulation and a closed lateral atrial appendage based on a surgical approach. This is the current data set. helps to prevent stroke in these patients. So if the patient undergoes open heart surgery and he has atrial fibrillation, get rid of the left atrial appendage, get it closed by surgical intervention. So this is a clear recommendation now. So these are the novelties which were presented by the new guidelines, which is more a forward approach towards risk factor management and re-evaluation, and a straightforward approach towards the stronger recommendation of a catheter ablation. So we have more trials, we have more evidence, and the authors tried their best to get this evidence implemented in the new guidelines recommendation.
Thank you. Thank you for that lovely summary. I have some questions for you. Let's say we have a patient who's multimorbid. They are admitted to hospital with fast AF. We rate control them in the acute situation. It's an older person who's had AF now for some years, and based on maybe the older guidelines, it was decided to rate control them. Would you, at this point, decide to change tactic and change to rhythm control based on new guidelines, or would you maybe continue rate controlling?
That's a very good question, and this is a question which is not answered by scientific evidence yet. But we are actually investigating many trials now where we first of all address elderly patients, which is, since on the demographic change, it's important to get more evidence in elderly patients, number one. And second, there are some hints that patients, even if they are for years in atrial fibrillation, that at a certain point of time, which might have been years in the past asymptomatic and not relevant, becomes relevant with respect to shortness of breath, heart failure signs. So still in these patients, you can pursue a rhythm control strategy. If you think that the atrial fibrillation is causal for the presentation at the ER or in your hospital. So what we do is we look at the patient, and if he's really multimorbid, as you said, in elderly, we are very close to put in a pacemaker and get rid of the AV node. That's one of the things which I already told you. Since in these patients, then you have a very good, we will say, long-term solution, since then you have a perfect rate control. The patient does not suffer anymore from bradyarrhythmia or tachyarrhythmia. We have perfectly rate control. It will never be insufficient. So this is something we evaluate. What we can do before, and that is something you have to discuss with the patient, we can retry to restore the sinus rhythm once, maybe under amiodarone treatment to get some, let's say, rhythm control pushed there by an antiarrhythmic drug for 2 or 3 weeks. Then you perform a cardioversion attempt. If this is successful, then you can see if the patient is really benefiting from the sinus rhythm, or he will say, first of all, it didn't work. You cannot reestablish sinus rhythm, or the patient says, maybe I'm bradycardic. I don't have any kind of chronotropic competence anymore. That's very, very common in elderly patients, that the sinus node, even if you restore sinus rhythm, that the sinus node is not anymore able to really increase heart rate or adapt the heart rate. So in these patients, you will get pretty fast a good answer if this patient is suitable for sinus rhythm and he benefits from sinus rhythm. If this is the case, you can pursue sinus rhythm. But if you don't see any benefits or it's not feasible to restore sinus rhythm, then after 4 weeks you already have the answer. Then put him on a clear rate control strategy. And in elderly multimorbid patients, we always say putting in a pacemaker, CRT or conduction system pacing device and getting rid of the AV node is a very sufficient, effective approach.
Okay. And staying with this example and this patient, logistically, could this patient, so for example, in the hospital I'm working with, there's no rhythmology section. So could this patient just be discharged and then with an outpatient follow-up in a clinic with rhythmology?
Yeah, of course, you first have to establish in your let's say, big center that you put some drugs, you prescribe him some drugs which control the rate. Like, this is important. If he is presenting with tachyarrhythmia, then you have a reason why he's presenting with some kind of symptoms. So then get rid of the tachyarrhythmia, put him on beta blockers, digitalis, or another combination. But if you see this is also leading to heart failure with reduced ejection fraction, then you have also to initiate heart failure treatment. And if the impression that he is suffering from edema and he's decompensated, then you have to hospitalize him, recompensate him, stabilize his rate, get heart failure treatment in this patient started, and then try to pursue a long-term, let's say, strategy for his AFib. Okay?
Yeah. But sorry, I meant to say, so once we've recompensated him, like, would this need an inter-hospital transfer, or would it be okay to do this as an outpatient?
If he's recompensated and the rate is more or less below 110, then you can say, okay, we have an appointment in the University Hospital in the outpatient clinic for electrophysiology or AF clinics. Some clinics have AF clinics. So there are people who are dedicated dealing with this rhythm disturbance, with the high experience and the whole spectrum of options which are provided for this heart rhythm disturbance. So that makes a lot of sense. And this goes in the future direction also of politics, that you have centers which deal with the acute problem and solve the acute problem, and then you transfer or refer these patients later on to a center of specialization. So I think what you just described is a scenario which we'll have to deal with and face in the future for sure, since we have also limited resources, and you have to deal with the acute problem, and later on the big hospital or big centers deal with the specific problem with really also sophisticated therapy options.
I wanted to know, in terms of anticoagulation, when do you start anticoagulating? For example, a patient who has experienced a stroke, and as part of the cause workup, they have their ECG or like telemetry for 24 hours, and then atrial fibrillation is detected. But so if I have 5 minutes of atrial fibrillation, is that significant?
In a patient with suffered from stroke, for me, it's significant. So if you have the diagnosis of atrial fibrillation, which is defined as more than 30 seconds in a classical ECG, then you have the diagnosis of AFib. And if this patient suffered from a stroke, you have clearly a causal factor identified which has to be treated. If you don't do so, it's actually it's a failure of treatment from as a physician. So in these patients, you have to start anticoagulation, in also taking into account that he has a certain bleeding risk after the stroke. So usually we say between 3 and 6 days after stroke, you can start with the anticoagulation. But this is also a decision which has to be taken by the neurologist. But most recent data actually suggests that an early onset of anticoagulation is actually in the most cases possible. So after 3 or 4 days, you can start your anticoagulation right away after you identified atrial fibrillation.
Okay. And I noticed in the new guideline, actually, I believe in the old guideline, there was the has bled, which was evaluating the risk of bleeding, but that's kind of removed from the newer guideline.
Yeah, I must say this has bled score was a number which should represent your bleeding risk. And the new authors of the guideline evaluated that this in clinical practice has no implementation. There is no really randomized data which has a real clear causal consequence of this HAS-BLED score. So what the authors now recommend is like assess all potential variable factors which affect the bleeding risk and try to optimize them. That's the only recommendation. Don't treat based on a score which has no clear big evidence in the literature. So if you have an indication for anticoagulation, go for anticoagulation, but try to optimize all risk factors which are modifiable with respect to the bleeding risk. Okay?
Mm-hmm. Yeah.
So don't take the score as one part of your decision making in this patient.
And for some patients with a high bleeding risk, they get a left atrial occluder.
This is not really true. It's actually right now, and it's a to-be recommendation still, not really high bleeding risk is the indication. So it's like if it's not feasible to establish oral anticoagulation therapy in the patient, or the patient suffered from a bleeding event representing a long-term bleeding risk for recurrent bleedings under oral anticoagulation, then you have to look for an alternative. And then the alternative is left atrial appendage occlusion. That's the current state of evidence which the guidelines refers to. So it means if you have taken oral anticoagulation and you're suffering from gastrointestinal bleeding, then one option could be, okay, we put in a left atrial appendage occluder, and we get rid of the oral anticoagulation. Thereby, we help you to prevent stroke, but on the other hand, we get rid of the oral anticoagulation and decrease your risk of a recurrent gastrointestinal bleeding. These are the assumptions you have to take into account. Nevertheless, there are this year 2 or 3 trials coming up which really investigated the non-inferiority of an occluder versus the novel oral anticoagulants. So if these trials come out positive, then you have for sure a good alternative to the oral anticoagulation. To date, the new guideline still says first-line therapy for stroke prevention is oral anticoagulation. If this is not feasible long term, then consider alternative left atrial appendage occluder. But if you ask me as an expert in this field, if you say, okay, what's your perspective? What's your guess for the future? My guess for the future is that left atrial appendage occlusion, not as an alternative, but even as an additive option, will gain more and more relevance. There's the LAOS 4 trial designed now. We start to recruit now these patients for this trial, which evaluate oral anticoagulation versus oral anticoagulation plus LAA occlusion. And you always stand more stable on 2 legs than on 1 leg. And I believe if the procedure is carried out without complications, then the combination of both will for sure be superior than only one option. But this is the hypothesis, which has to be proven. And in patients which suffer from bleeding or cannot take oral anticoagulation, this is the best alternative to get in left atrial appendage occlusion. Since this procedure as such got really established with a high success rate and a low complication rate.
And for patients who are getting a left atrial appendage occluder, is there an overlap where they should still be anticoagulated?
Yeah, that's a very important factor. So there are different providers or industry providers which manufacture these devices. So the initial device from Boston Scientific, the Watchman, was the most common, or let's say the most famous device based on his biggest track record on scientific evaluation and randomized trials, which were initially requires oral anticoagulation, then followed by dual antiplatelet therapy, and then followed by single antiplatelet therapy. Other devices only say there are no trials proving that, but they recommend dual antiplatelet therapy and after single antiplatelet therapy. But a lot of trials are ongoing to de-escalate this kind of, let's say, very potent regime at the beginning to less potent regimes, to also see if it's possible with less potent anticoagulation to get this device implanted and still maintain or enable the so-called they get this overskinned by endothelium then after 3 or 6 months. So the answer to your question short is yes, they need something for a certain time, which then gets de-escalated after latest 6 months. Okay?
Yeah. When you ablate and pace, do they still need to be anticoagulated?
Of course. That's the rhythm control strategy which I described. Is you leave them in atrial fibrillation, but you get rid of the AV node and control the rate via pacemaker. So both atria are still fibrillating. So you have still stasis. So you accept the atrial fibrillation, but you disconnect the atrium from the ventricle. Thereby you control the ventricular heart rate by the pacemaker, but you keep the atria in atrial fibrillation, which means you have still stasis and you for sure have still the highest stroke risk in relation to your rhythm, I would say. Yeah. Then you have permanent atrial fibrillation, and then you have always a stasis factor based on lower flow velocities in the atrium and especially in the appendage.
Thank you for clarifying that. Also, in terms of terminology, is ablation the same as pulmonary vein isolation?
No, ablation is just the technique of getting a catheter to a place and apply a certain kind of energy, which results in cardiomyocyte death. So you can do that by heating, by radiofrequency ablation. So this is the most common old-fashioned historical kind of ablation, based really 3-4 decades ago, it was also DC, but we got rid of that. So now it was RF for radiofrequency ablation. Then the cryo technology came into, which uses freezing temperatures to destroy cardiomyocytes, to get rid of them. And the most recent technology, which is really a very hot topic, is so-called electroporation by pulsed field ablation therapy. But coming back to your question, ablation is just describing a kind of applying kind of energy source or anything to the cardiac tissue to get rid of cardiomyocytes, which might be relevant for initiating, maintaining a heart rhythm disturbance. The pulmonary vein isolation is a very specific subtype of an ablation therapy, which uses ablation as a technique to electrically isolate the pulmonary veins from the left atrial myocardium structure. The hypothesis behind this is like a very famous French electrophysiologist, Michel Hazaguer, in 1998 described that he observed that muscle sleeves, which really are located within the pulmonary veins, have a certain different electrical physiological phenotype, which is showing ectopic activity. So the hypothesis was like these muscle cells or sleeves within the veins develop ectopic activity, and this ectopic activity is contributing to the initiation and the maintenance of atrial fibrillation. So his hypothesis was, if I disconnect this area of pulmonary vein electrical ectopic, muscle sleeves from the whole atrium, I won't let these disturbers get into my atrium, and thereby I stabilize the rhythm of the atrium. Okay, so this pulmonary vein isolation is a very specific subtype of ablation, and ablation is used to get electrical isolation from the vein structure from the left atrium. The blood flow is still maintained, since you just get a scarring on the atrial side of the tissue to have an electrical isolation, a barrier of electrical conductance between the atrium and the pulmonary vein, where ectopic foci are located.
I see in the description of symptoms for atrial fibrillation, there's this modified European Heart Rhythm Association. So
ERA score. We call it ERA score.
ERA score. Yeah, I was wondering, because I don't come across this in my practice. You know, I think everyone's familiar with the NIHA score, which is for heart failure. Is this score, is it used in daily practice?
It has to be. If you're diagnosing atrial fibrillation, you have to assess, like what the guidelines also recommend is, okay, when was it initially diagnosed? What is your CHA2DS2-VASc score for assessing the stroke risk? And what's the ERA score? Because back in the days, you treated atrial fibrillation not as a prognostic factor, more based on the symptomatic situation of the patient. So if you have ERA score 1, this means the patient is asymptomatic. So if a patient has ERA score 1, in the past, you didn't have any reasoning to put him back on atrial fibrillation by ablation, for example. So you have to state the graduation of the symptoms, since this is also having a consequence on the recommendation strength of how hard I have to pursue the rhythm control. Because if you have ERA score 4, that means atrial fibrillation disables you from any daily activity. So the patient lays down in bed because he is not able to do anything anymore. This is a very strong reasoning to try to get the patients back to sinus rhythm, right? So this is like giving you guidance how hard or how strong you want to pursue a rhythm control strategy, since the ERA score is a representative how much does the patient suffer actually, one representative how much does the patient suffer from the atrial fibrillation. And you have ERA score 1, the motivation to get the patient back in atrial fibrillation. Also, the patient's motivation is maybe not so high since he has no symptoms in daily business, in daily activity. And therefore, we always assess ERA score. At least you have to have a 2A to get an ablation, since if you have 2A, you don't have any symptoms.
Okay. Can the ERA score overlap with the NIHA score?
Of course.
Yeah.
They are more or less kind of in analogy. It means NIHA 1 means you have signs of heart failure but no symptoms. ERA 1 means you have no symptoms, so it's the same. And 4 is like you're completely down and you cannot do any kind of exercise or movement, whatever, with NYHA 4, and the same is with ERA 4. It's the same. The patient is lying down since AF disables him from anything in daily activity. In 3 means like you can only do really low level activity. If you do more, you're impaired to do that by atrial fibrillation. So the grading is in a very strong analogy to the NYHA grading. The NYHA grading just refers to the heart failure, but the ERA refers to the atrial fibrillation. So the difference is, NYHA you have always present because the heart failure is there, and then you get your NYHA grading. AF is not always present. So if you have paroxysmal AF, you have to evaluate if AF is present, then how much is AF affecting your activity range or your daily life. So ERA just refers to the time which you are in AF, while the NYHA score, NYHA classification refers to the older time, since heart failure is always present.
Thank you. I think that is all my questions. I really appreciate you answering everything and giving us your expert knowledge and just being able to explain it all. Is there anything, any take-home message that I didn't cover that you wanted to get off your chest?
Like with all the young generations, and all the artificial intelligence, I still have to say, you have to look at the patient, you have to talk to the patient, ask him questions about his daily life, try to assess things which are potential risk factors in the patient. So you still need to be in contact with the patient, to talk to the patient, ask him the right questions, and really try to evaluate the individual situation of the patient in front of you. And then after that, you can decide, based on the guideline recommendation, this path you have to go on, which are the potential treatment options for this patient. That's the only thing. So guidelines are good, but in the end, you have to sit in front of the patient and deal with him, and really have to take your time to focus on this individual in front of you.
Yeah, I feel like at a lot of the courses that I do, the experts, they always come back to this point. Always, they'll be like, and don't forget, the most important thing is to talk to patients. So yeah, thank you so much for reminding us for that. Thank you so much for your time.
It was my pleasure, and thank you very much for inviting me. And if you have another topic we want to talk about, you're always open to contact me again. So it was my pleasure. I hope that people will listen to it, and maybe I could help to elucidate or describe one of the scenarios which were not clear. And I hope I could contribute a little bit to the knowledge and understanding of atrial fibrillation in the current time.
Vielen Dank, dass du heute wieder zugehört hast und unser Gast gewesen bist. Wir hoffen sehr, dass dir dieser Beitrag gefallen hat und du etwas für deinen klinischen Alltag mitnehmen konntest. Wenn dem so sein sollte, dann freuen wir uns sehr über eine positive Bewertung bei Apple Podcasts. Falls du Lust hast mitzumachen und es einen Themenbereich gibt, in dem du dich besonders gut auskennst, dann melde dich doch gerne unter kontakt@klinisch-relevant.de. Gleiches gilt, wenn du Themenvorschläge oder konstruktive Kritik für uns hast. An dieser Stelle auch der Hinweis auf unseren Newsletter, den du unter www.klinisch-relevant.de abonnieren kannst und der dich immer auf dem Laufenden hält. Wenn du dich für unseren Newsletter einträgst, bekommst du einen 5-Euro-Gutschein, mit dem du in unserer Fortbildungsakademie einkaufen kannst. Wir wünschen dir jetzt bis zum nächsten Mal eine gute Zeit und freuen uns, wenn du bald wieder einschaltest. Pass auf dich auf, bleib gesund. Bis zum nächsten Mal. Ciao.